stage, and hence it should be very carefully observed. This is a very what you call as the disturbing phase to the patient is concerned. And the stage 3, or it's also known as stage of surgical anesthesia, this extends from onset of regular respiration to the cessation of spontaneous breathing. So the spontaneous breathing will be it is very slow, and this has been divided into 4 planes, which may be distinguished as the plane 1. So here the rolling up of the eyeballs will be seen, and this plane ends when eye becomes fixed once. So that's the stages where we can start the surgery. And the plane 2 is loss of corneal and the laryngeal reflexes, because in this particular stage the animal is unable to swallow, or the respiration becomes very slow, and the cornea fixes, and the both eyes are fixed. And in case of plane 3, pupil starts dilating and right reflex is totally lost. So if you put the torch also, the pupillary constrictions will not be seen in case of the patient is concerned. Whereas the plane 4, it is the paralysis of the intercostal muscles, and shallow abdominal respiration will be seen, because usually the respiration will be abdominal type, but it will be very shallow, and the pupillary dilatation will be seen. So anesthesia passes to deeper planes progressively, muscular tone decreases, blood pressure falls, and heart rate increases with a weak pulse, and respiration decreases in depth, and later it frequently also, and thoracic respiration lags behind the abdominal respiration. So usually the thoracic respiration lag, and the abdominal respiration take the upper part. And the last stage of this particularly the stages of anesthesia are the stage of medullary paralysis, or the cessation of breathing to failure of circulation and death. Ultimately, usually the brain gets paralyzed and death will be seen. So what are all the signs? Here the pupil is widely dilated, muscles are totally flabby, and pulse is already or imperceptible, and blood pressure will be very low. So if you administer the injectable anesthetics overdose, then you will get this particular state, and it's very difficult to make the patient to recover to the normal. And many of the above indices of the anesthesia have been robbed by the use of the atropine, or the pupillary and heart rate can also be monitored, and the morphine, respiration and pupillary, and so a few of the muscle relaxants like the many varieties of the muscle relaxants and the anesthetic with muscle relaxation like halothane, etc., will induce all the planes of this stages of this surgical anesthesia. So the depth of anesthesia will be very high in case of the initiation of this stage of medullary paralysis, and once the patient comes to this particular state, it is very difficult to get him back to the original state is concerned. Even though we use the antidotes, then it is not useful to the patient. If eyelash reflex is present and the patient is making swallowing movement, stage 2 has not been reached. How to confirm the anesthesia has been reached or not? So the patient is making swallowing movement. If you observe the throat region, then the involuntary swallowing movements you can see on the patient, and it indicates that stage 2 has not been reached at all, the delirium stage. The loss of response to painful stimuli, especially pressure on upper nasal border of the orbit, and stage 3 has been reached. Means if we pinch the pressure on upper nasal border, then if the animal is not responding, means we can say that the stage 3 is seen cardiac and respiratory depressions are the signs of deep anesthesia. So the heart rate and respiratory rate both are decreased to a maximum extent so that the patient will breathe in a very slow and feeble manner, and the heart rate also becomes very slow in case of the stage 3 surgical anesthesia is concerned. And usually most of the surgeries are conducted in this particular stage. So in the present days, what there is a practice is anesthesia is generally kept very light. Adequate analgesia, amnesia, and muscle relaxations are produced by the use of initial administration of the intravenous drugs, which is maintained by the inhaled agents. And pre-medications with CNS depressants and opioids and their concurrent use lower maximum alveolar concentration of the anesthetic. Means if you administer sometimes the ketamine xylazine combinations or thiopentane sodium to the animal and induce or maintain the anesthesia by an inhaled anesthetics, then the lower MAC of the inhaled anesthetic is sufficient to induce the complete anesthesia. So when there is a combination of two inhalational anesthetics, that's the nitrous oxide and isoflurane, the MACs are additive, maximum alveolar concentration are the one. So once again, to make you to remember the MACs or maximum alveolar concentration is the one, the concentration of the anesthetic in alveoli or the airway, which induces the analgesia and anesthesia in 50% of the patients. So the lower concentration of each is required. Example 0.5 MAC of nitrous oxide or the laughing gas is 53% and 0.5 MAC of the what you call as the isoflurane is 0.6%, and these produce CNS depression equivalent to 1 MAC of isoflurane alone, because isoflurane is a potent anesthetic. So the MAC of the isoflurane as well as the nitrous oxide are almost all they are similar in nature. The dose response relationship of the inhalant anesthetic is very steep. Just 30% of higher concentration of immobilizers and 95% of the subjects. So the concentration of inhalation anesthetics exceeding 1.5 MAC are rarely used, and 2 to 3 MAC is often lethal. That means it is going to take the patient to stage 4 this anesthesia, or also called as stage of the medullary paralysis. And anesthetized subjects generally wake up when anesthetic concentration falls below 0.4 of the 0.4 of the MAC. So the concentration, as it is decreases, the patient is going to arouse, or he is going to recover from the anesthesia. So this is about the concentrations and certain terminologies of anesthesia. And coming to the mechanism of the general anesthesia is concerned, the Mayer-Overton rule is a unitary theory of the anesthesia. This is a very specific rule. Always this is a FAQ, frequently asked question. What is a Mayer-Overton rule? So here the lipid water partition coefficient is important. Then the gases are highly lipid soluble, therefore they can easily enter the neurons after crossing the blood-brain barrier. So after entry, the agents, they cause disturbance in the patient's consciousness. Then after entry, they cause disturbance in the physical chemistry of the neuronal membrane, and this is known as the fluidization therapy. So they change the varieties of the physical chemistry of the neuronal membranes, and this is known as the fluidization therapy. Finally, obliteration of sodium channels and refusal of the depolarization, it occurs. And the coming to the potency of a gas correlated with its solubility in olive oil, the or olive oil or water coefficient or the ratio, and here the lipid bilayer as only target for the anesthetic action, and clear exceptions have been found now in between so many anesthetic agents. The unitary theory has been discarded totally now, whereas the Mayer-Overton rule is somehow it is ongoing. And for the inhalation anesthetics, the minimum alveolar concentration or MAC1 is defined as the minimum alveolar concentration that prevents the movement in response to surgical stimulation in 50% of the subjects and correlates with oil gas partition coefficient usually. And practically, alveolar concentration can be monitored continuously by measuring end tidal anesthetic concentration using the spectrometry, and the end point, especially the immobilization, can be assumed, can be measured. And other endpoints are the verbal commands or memory, etc. So if you give some commands orally to the patient, he will hear. That's also the another practicality. For the intravenous agents, potency of IV agent is defined in the different patterns, whereas the MAC is a standard terminology for the gaseous anesthetics, whereas the potency of IV agent is defined as the free plasma concentration at equilibrium that produces loss of response to surgical incision in 50% of the subjects. To repeat again, the free plasma concentration at equilibrium that produces loss of response to surgical incision in 50% of the subject, just like the MAC, maximum alveolar concentration. So it is very difficult to measure. Of course, the no availability method to measure blood and plasma concentration continuously, suddenly, just like pricking a probe inside the artery or the vein and monitor it on the using a machine. That's not possible now. Whereas the free concentration at the site of the action cannot be measured. So this is a very difficult situation. The anesthetist, by his own experiences, he has to study all these things and determine what quantity of the anesthetic need to be administered. Whereas the MAC explain only capacity of the anesthetics to enter the central nervous system and attain sufficient concentration, but not the maximum action, mode of action. The mode of action of the anesthetic is not going to be explained by the MAC. And the modern theory on mechanism of general anesthesia. So the general anesthetic mainly act by interaction with membrane proteins, so they may be receptors. The different agents, different molecular mechanism is there, and few of the agents will act using a common mechanism. So major sites of the anesthesia are the thalamus and RAS, the RAS system and the hippocampus and spinal cord. These are all the major sites of the anesthetic effect, and the major targets are ligand gated ion channels usually. The important one in among these things is the GABA A receptor, the gated chloride ion channel complexes. GABA A receptor gated chloride ion channels are very important in induction of the anesthesia. And the many inhalant anesthetics are acting by this specific mechanism, especially the maybe the halothane ether, and of course the barbiturates and benzodiazepines and the propofol. It induces the anesthesia by with the action on the GABA A type of the receptors. So what happens if they come and bind with the GABA A type of the receptor? It is going to potentiate the GABA A to open chloride channels. So also direct activation of the chloride channel, especially the barbiturates, and they are going to increase the bind with the chloride ion channels. Then there will be increase in the inflow of the chlorides, and there will be unconsciousness will be seen. So you can see the structure of the GABA. So it is a different structure than that of the earlier receptors. It is having varieties of the sites, receptor sites on the membrane, and its neurons at the synapse is concerned. So GABA is an endogenous compound, causes GABA A to open. Gamma amino butyric acid is a neurotransmitter. It is going to cause the GABA to open. Whereas the general anesthetics don't bind at the same site with GABA. So usually the GABA is going to bind with that of the alpha site, whereas the alpha, beta and gamma type of these subtypes of this protein, particularly GABA A receptor complex will be present, and the alcohol is going to act on the base stem of the GABA A receptor and is going to bind with that of the particular site. And whatever may be the drug, ultimately the chloride ion channel is going to open inside from outside, and it is going to induce the anesthesia, the benzodiazepines and the ethanol. They are going to act on different site. The barbiturates are going to act on this particular site very near to the alpha, beta and gamma type of the subtype of the receptors. So the GABA A receptor gated chloride ion channels are normally, they mediate the effect of gamma amino butyric acid, the major inhibitory neurotransmitter in the brain. So GABA A receptor found throughout the central nervous system. Of course, this type of the receptor is present in the worms, especially in the roundworm, and ivermectin is going to act and cause the excitation of this type of the receptor. So there is the paralysis of the worms, whereas the ivermectin is not going to cross the blood-brain barrier, hence no effect, especially on the other mammals. And most abundant type of the receptors, they are the inhibitory type of the receptor. And if you use the agonist GABA, then the action of the GABA on the GABAergic receptors is going to increase the chloride ion concentrations inside the neuron and going to have the unconscious action. So this is located in the postsynaptic membrane, and ligand binding causes the conformational changes, especially in the leading to opening up of the central pore of the chloride ion channels. So the concentration gradient is there, so it is going to open inside, and net inhibitory effect reducing activity of the neurons. So we know that if the chloride ion is activated, there is hyperpolarization in the normal cell. Whereas here also the same thing happens, more and more chlorides if coming inside the cell or the neuron, then there is more and more unconsciousness will be present, and general anesthetics bind with these channels and cause opening and potentiation of these inhibitory channels, leading to inhibition and anesthesia. Here you can see the GABA receptors, they are going to bind with that of the barbiturates or on a specific site they are going to bind, whereas the steroid type of the anesthetics and the GABA is going to bind with that of alpha and gamma and beta, all the type of the subtypes. Then the ethanol is to act on the base of this GABA receptor complex. And another neurotransmitter is there, that's the glycine. Glycine activates the chloride ion channels, the spinal cord and medulla. So the barbiturates, the propofol and other inhalation anesthetics are also acting on this particular type of the receptor. Then the another thing, the NMDA, the ketamine and the other anesthetics, dissociative anesthetics are acting through NMDA, N-methyl D-aspartate type of the glutamate receptors, or the aspartate and glutamate type of the receptors are also very important. Whereas this nitrous oxide and ketamine, they selectively inhibit the NMDA type of the receptor. They are not going to act on the GABA, but the nitrous oxide and ketamine. So that's why it produces a very characteristic type of the anesthesia, ketamine. So it is known as the dissociative anesthetic, ketamine. Usually it is used in case of cats and dogs for the minor surgeries are conducted. Of course, in case of human being also, the ketamine is used very commonly. And these inhibit the neuronal channels gated by nicotinic cholinergic receptors, and the analgesia and amnesia is induced. The classical example of the agents which are acting through this type of the receptors are the barbituric and fluorinated anesthetic, isoflurane, sevoflurane, and many type of the fluorinated anesthetics are going to act in similar pattern. And coming to the classification of the drugs in general, mainly the general anesthetics are classified into the inhalant type of the anesthetics and the intravenous type of the analgesic. Inhalation is usually caused by the gases. Usually, it's a gas is a nitric oxide, whereas the inhalation anesthesia is also caused by the volatile liquids like ether, halothane, enflurane, isoflurane, and desflurane and sevoflurane are the fluorinated anesthetics. Whereas intravenous anesthetics are induced by varieties of the drugs like the thiopentone sodium, methoxyetone sodium, propofol, and etomidate sodium. And all these are the administered through the veins. Whereas the benzodiazepines are very slowly acting anesthetics, and the drugs classical example of this category are diazepam, lorazepam, then the lidepam and midazolam. And dissociative anesthetics, are ketamine and the ketamine or ether, the ketamine, ketal etc. They are going to act on the NMDA type of the receptor. Whereas the neuroleptic analgesia is the another type of the these anesthetic agents, the fentanyl and droperidol. They are all the neurolept analgesia. So we have to study all these agents in detail in the forthcoming contact hours or the classes. So tomorrow we are going to learn about the in detail about this particular class of the drugs. What are all the inhalation type of the anesthetics, intravenous and different agents, how they are going to induce the anesthesia, and also the different type of the anesthetic agents with the different type of the mechanism of action.